Before we build anything, we have to clear up a classic first-year mistake, confusing pharmacognosy with pharmaceutics. Pharmacognosy is strictly the study of crude, naturally derived drugs extracted directly from plant, animal, or mineral sources. Pharmaceutics is the science and art of taking a raw, active pharmaceutical ingredient, or API, the actual chemical that treats the disease, and converting it into a viable dosage form a patient can use. Look at paracetamol. As a raw, synthesized white powder, it is biologically useless. You cannot accurately measure a safe dose of raw powder at home, and your body cannot absorb it efficiently in that state. That raw material requires a highly engineered delivery mechanism to function safely. Designing and manufacturing those delivery mechanisms is the core purpose of the pharmaceutical industry. Scaling this physical process to produce exact doses for millions of people introduces a massive logistical challenge. Taking one raw molecule and splaying its production into tablets, syrups, and intravenous lines means multiplying the physical engineering requirements and the points of failure. Mastering the physical chemistry is only the first step. The human practitioners executing these conversions must also be standardized by law. How do we guarantee that a chemical compressed in a massive industrial facility remains completely identical and safe by the time it reaches a local pharmacy counter? To understand the modern systems that prevent structural failures across the supply chain, we have to examine the historical chaos that forced those rules into existence. Before the 1800s, the dominant medical framework in India was the Ayurveda system. In this era, medicine and pharmacy were entirely integrated. The physician, the Vaidya, personally prepared and dispensed treatments based on classical texts like the Charaka Samhita. The standalone pharmacist did not exist. That integrated system fractured during the British colonial period, which introduced Western allopathic medicine to the subcontinent. As dedicated dispensaries and medical stores appeared, the roles of prescribing and dispensing split. This created the distinct profession of the pharmacist. Early legislation, like the Dangerous Drugs Act of 1930, attempted to control specific narcotics, but the actual profession of pharmacy was left completely unregulated. There were no formal education requirements. Anyone could set up a shop, mix chemicals, and sell complex medicines. This lack of oversight created a severe public health void. By the time India gained independence in 1947, state intervention was inevitable. The post-independence era brought an immediate regulatory reckoning for the entire healthcare system. The turning point arrived with the passage of the Pharmacy Act of 1948. The act explicitly closed the colonial-era loopholes. It mandated that only a legally registered pharmacist could dispense medication, completely barring unqualified sellers from the practice. That same year, the government established the Pharmacy Council of India, or PCI. The PCI serves as the apex governing body. It strictly regulates the curriculum across every tier of pharmacy education in the country, from a 2-year D.Pharm diploma to a 6-year Pharm.D doctorate. These standards are updated continuously, leading to the current education regulations of 2020 that dictate modern training. While education was formalized, the government simultaneously pushed the commercial sector to replace British pharmaceutical imports with indigenous manufacturing. The Pharmacy Act of 1948 successfully standardized the human professionals, but the chemical drugs they manufactured still required a universal rulebook. Transitioning from regulating the practitioner to regulating the chemistry requires a different mechanism entirely. That mechanism is the Pharmacopoeia. A Pharmacopoeia is an official, government-published book that dictates the precise standards for a medicine's identity, purity, strength, and quality. The foundational building block of this text is the monograph. A monograph is an exhaustive, individualized standard dedicated to one single drug. It dictates exactly how to run chemical identification tests, the allowable impurity thresholds, and the strict environmental storage conditions required to keep the molecule stable. Because of these pharmacopoeial standards, a tablet manufactured in a facility in Mumbai will be chemically and functionally identical to one manufactured in Chennai. In India, this specific rulebook is the Indian Pharmacopoeia, or IP. It is updated roughly every 5 years by the Indian Pharmacopoeia Commission, located in Ghaziabad. Other regions enforce their own standards, most notably the British Pharmacopoeia, the BP, and the United States Pharmacopoeia, the USP. This table highlights a common exam scenario. If a drug's manufacturing standards conflict between the IP, the BP, and the USP, which rules apply? The rule of legal precedence is absolute. Within Indian jurisdiction, the Indian Pharmacopoeia overrules all foreign texts in a court of law. These legally binding texts operate differently from reference books like the Upstra Pharmacopoeia, commonly referred to as Martindale. Martindale compiles vast amounts of drug information from across the globe, but unlike the IP, it holds no official legal authority. Maintaining and enforcing a native pharmacopoeia is the ultimate step required for a nation to achieve sovereignty over its chemical supply chain. Over the last century, these strict scientific constraints and comprehensive legal frameworks together built a truly massive industrial engine. Pharmaceutics allows us to engineer the physical dosage, the IP enforces the chemical rules, and the PCI guarantees a qualified workforce to execute it. Professional bodies like the Indian Drug Manufacturers Association, or IDMA, then scale this architecture into commercial industry. To export these medicines across borders, manufacturers must also comply with international standards, such as the International Pharmacopoeia published by the World Health Organization. Combining rigorous domestic standards with global compliance allowed India to stop importing colonial medicine and become the largest exporter of generic drugs on Earth, earning it the title Pharmacy of the World. Let's consolidate the exact mechanics of this system for your exams. 1. The Pharmacy Act of 1948 is the historical cornerstone that formalized the profession in India. 2. The PCI regulates pharmacy education, while the IPC publishes the Pharmacopoeia. 3. The IP holds absolute legal supremacy over the BP and USP within Indian borders. 4. A monograph is the exhaustive, individual standard dedicated to one single drug. These laws and definitions provide the literal blueprint that allows the science of pharmaceutics to safely treat billions of people worldwide.